Okay, so let's start today's class. Today I'm going to talk about pathology of esophagus, and then I enter into the pathology of stomach. Both of these are important classes. Okay, so pay attention. Now let's list what are the common disease or disorders of pathology of esophagus. Now first of them, congenital and mechanical disorders like tracheoesophageal fistula, esophageal wave, and achalasia cardia. Tracheoesophageal fistula, esophageal wave, and achalasia cardia. I'll talk about each of them in the subsequent slide. Okay, just let's take the name here. Hematomesis and esophageal bleeding. Under this heading, we'll discuss Mallory-Weiss syndrome and esophageal varices. The third one is esophagitis, and under this heading, we are going to talk mainly about GERD or gastroesophageal reflux disease, which will cause reflux esophagitis, and then Barrett esophagus, which is a long-term complication of GERD. And we'll complete this topic by talking about esophageal carcinoma, and two important types are there: squamous cell carcinoma of the esophagus and adenocarcinoma. So you can expect some questions in the exam from this topic. Now let's start. Congenital and mechanical disorders. The important one is tracheoesophageal fistula. Look at the short form here. Okay. Tracheoesophageal fistula. It's written TEF or TOF. Now when we write TOF, it almost looks like tetralogy of Fallot. Okay, these are completely different condition though, so we need to careful when we write this short form. So in the exam, writing short form is discouraged. Okay, we can write very typical short form like VSD. Yes, that is fine because there is no other similar type of terms. But don't write TOF, and if you are talking about GI tract disorders, it may be quite confusing. Okay, so there are two types of tracheoesophageal fistula, congenital and acquired. Now, fistula means this is a connection between two tubes here, and those two tubes are trachea and esophagus. So this is the congenital connection between esophagus and trachea, and it is there or it arises due to failed fusion of tracheoesophageal ridges, which occurs during third week of embryological development. Now, trachea and esophagus, they are two different tubes. We all know that. Their function is completely different. Somehow, because of the embryological abnormality, there is connection exists between trachea and esophagus, which is called fistula, tracheoesophageal fistula. One very important point is, it is often associated with esophageal atresia. Esophageal atresia. Now, what do you mean by atresia? In the few classes ago, I discussed this in GI tract also. Atresia means the tube, okay, is not connected. It is abruptly ended in one area, then again there is a gap, and then tube is there. Okay, so there is a gap between two ends of the tube. Atresia, very important point. I'll show a different picture later on, then you will know what I'm talking about here. Now, how it presents, this is quite interesting. Now these babies, they produce a lot of froth. Okay, these babies produce a lot of froth after birth or at the time of birth. Now let me explain this. Because of this esophageal atresia, the baby cannot swallow saliva. Okay, it cannot reach the stomach. There is a tube, so that tube is filled and the saliva will be regurgitated, and then all that froth will come outside. Now even a normal baby produce some of the froth, okay, which we will aspirate, but in this baby the frothing is excessive. So a doctor who is present there should ask the question, why this baby is producing excessive froth. Okay, so this is how we suspect the disease, then we'll confirm it. Now, how we confirm? The confirmation or diagnosis is done by passing a rubber catheter into the esophagus, which coils up, and after that we take the contrast X-ray. Now see that. So what we do now, we have suspected the esophagus is blind, okay, it has atresia. So we put a red rubber catheter, but it doesn't go downwards, it doesn't reach the stomach because there is no connection at all. So it will coils up and come backwards. It will coil up and come backward, okay. So this is the process of diagnosis, and we can also diagnose by doing contrast X-ray. This is a different way. Now, one important point written here is aspiration. This aspiration is done by two ways. One, if we fail to diagnose and give milk to the baby will definitely aspirate the milk. Second one, even after a failure to swallow that particular saliva, when saliva is there in the oral cavity, it may trickle down into the airway. So these are the two ways. Now, aspiration of saliva is not that lethal, okay. Probably the baby will not have any severe signs and symptoms, but aspiration of milk can definitely give rise to aspiration pneumonia. On the other hand, the acquired tracheoesophageal fistula is the sequelae of a surgical procedure such as a laryngectomy, and this is a accidental, okay, like the surgeon never wanted to create a fistula like that, but accidentally, because of surgical trauma, it can happen. And it can also occur because of pressure necrosis by the tracheostomy tube. Now, you all know what is tracheostomy. We cut the anterior wall of the trachea and put a tube there. This is an alternative type of airway. But if this tube remains there for a longer duration, maybe more than 7 days, then the tube itself will give pressure necrosis of the posterior wall of the trachea now, and posterior to the trachea there is esophagus, so anterior wall of the esophagus also may be involved. This is the way fistulization occurs between trachea and esophagus. This is acquired one. This is not congenital because it was not present there from the time of birth. Now, so please pay attention here, all those things which we talk, okay, let me explain one after other. Now see here, this is trachea. Trachea is divided into two bronchi, you can clearly see here, these are the tracheal ring. Now this is esophagus. Now see here, this is called atresia. The esophagus, the upper part of the esophagus is blindly ended, and the lower part is also, there is no connection with the upper, and there is a big gap between them. This is called atresia. Okay, now see here. Now in this situation, there is no connection between the esophagus and trachea. Strictly speaking, there is no fistula here, but still aspiration can occur, because if we give feeding to the baby, look at this tube is blind, so this tube is very easily filled by the milk, and milk will spill over when this tube is filled. It will go anteriorly towards the airway, so aspiration can still happen. The second one, this is a very lethal one. See here, the esophagus is directly connected or continuous with trachea. So whatever the baby is swallowing, it is directly going into the lung. Okay, very complicated one. Third, or C, this is the most common variety. Okay, C is the most common variety. The upper, okay, part of the esophagus is a blind tube, and the lower part of the esophagus is connected with the trachea. So in this situation also aspiration can happen. How? After this tube is completely filled with the milk, it will trickle, okay, it will trickle anteriorly to the airway. This is D, okay. There is no lower part of the esophagus at all, only the upper part of the esophagus is there, and it is blindly ended. Aspiration can occur here as well. And E is called H type of fistula. H. Look at the letter H here, isn't it? Okay, see here, H. This is called H type, and it is diagnosed a little bit late. So these are the 5 varieties of tracheoesophageal fistula. C is the most common one. Now one common problem here, if we diagnose this type of baby, okay, I've already told you how to diagnose. We have to refer them to the surgeon. Okay, we have to refer them to the cardiothoracic surgeon or pediatric surgeon, and they will take over this case. Now let's talk about esophageal wave, some of the important points only. Okay, there are a lot of pathology which we have combined together inside this topic. Now esophageal wave is a wave like protrusion. Or wave is made mainly because of the membrane, okay, or mucosa. So wave like protrusion of the esophageal mucosa into the lumen, and this wave can obstruct, okay, this wave can obstruct the esophagus. As a result of that, dysphagia may be there. Now, dysphagia is difficulty in swallowing. At the same time, pain may also occur, but more common is the dysphagia. It can be congenital or acquired. Okay, congenital or acquired, and one of the acquired variety of esophageal wave is called Plummer-Vinson syndrome. So this Plummer-Vinson syndrome is a combination of esophageal wave. Okay, it has a high risk of development into squamous cell carcinoma of the esophagus, and it is strongly associated with iron deficiency anemia as well. And the common sex is middle-aged woman. So combination of iron deficiency anemia, esophageal wave, high risk of squamous cell carcinoma of esophagus, and common in middle-aged women. This is called Plummer-Vinson syndrome, one of the common questions which will be asked in your exam. Okay, now after that, let's talk about Achalasia. Okay, Achalasia or Achalasia cardia. Now, cardia term is used, okay, cardia term is used because it is very near to the cardiac end of the stomach. Now, our stomach, okay, the upper part or upper end is called cardiac end. Lower end is called pyloric end. That's why some of the textbook call it Achalasia cardia, some other only call it Achalasia. That is an important point. Now, what is this? This achalasia means the lower esophageal sphincter, which is present between the lower end of the esophagus and the stomach, failed to relax. Okay, it failed to relax when we are swallowing the food. Now what happens when it fails to relax? It acts like an obstructed segment. So proximal to that, okay, there is continuous or constant type of peristaltic movement which is trying to push the fluid and food distally, but that cannot happen because it is not relaxing. So it acts like an obstructed segment there. This condition is known as achalasia. So etiology, regarding the etiology or the cause, okay, it is idiopathic in most of the cases. But in South American countries, if somebody presents with achalasia, then we think about Chagas disease. Okay, then we think about Chagas disease. Now, Chagas disease is caused by Trypanosoma cruzi. Let me write that name here. Okay, Trypanosoma cruzi. Wait. Okay, Trypanosoma cruzi. So this is the causative agent of Chagas disease, and it is very common in South American countries like Brazil. Now, what is the presentation of achalasia cardia? It has presentation of progressive dysphagia and chest pain. Now, this progressive dysphagia is an important one here. The progressive means it is increasing day by day. Okay, every day it is getting more severe and severe. Progressive, and at the same time, because of constant peristaltic movement. Okay, because of constant peristaltic movement of the proximal part of the esophagus, there is chest pain also. You just understand like this: the upper part of the esophagus is constantly contracting, resulting in chest pain. Now, one more thing is also happening here: aspiration. That aspiration is one of the complications which is highlighted a bit below. Aspiration is common because food and fluid is not going distally because of the obstructed segment. So that tube is get filled and then it will trickle down anteriorly, resulting in aspiration. Now, what are the gross and microscopic feature of achalasia? Now, there is esophageal dilation proximal to the lower esophageal sphincter. I already told you that. And according to the microscopic exam, there is loss of ganglion cells in the myenteric plexus. Now, esophagus is a part of our GI tract. It has also got 4 layers. Okay, and in between the muscle layer, there is myenteric plexus. Now, if these myenteric plexus or the cells which are present there are absent, then achalasia cardia happen. Now, I like you to compare this condition with Hirschsprung's disease immediately. That is the way you should learn medicine: comparing and contrasting. Okay. Now, in Hirschsprung's disease, both Mischner plexus and myenteric plexus in the rectum is involved. They are absent. In this case, only myenteric plexus are absent. Don't forget that. Now, complication of achalasia: there is increased risk of esophageal carcinoma by 2 to 7% than general population. So it is a precancerous lesion, you can say. There is a high chance of aspiration pneumonia because the tube is blocked. When the esophagus gets filled, okay, the fluid can trickle down anteriorly into the airway. That is called aspiration. And one very important problem is epiphrenic diverticula. Epiphrenic diverticula may develop. Now, diverticula is outpouching from this type of tube. Because of the excessive pressure inside, most of the time, the mucosa and the submucosa may outpouch just like an aneurysm. We don't use the term aneurysm here. This is a part of a GI tract, okay? We use the term diverticulum. So this is called epiphrenic diverticulum. This is the one. And epiphrenic means, remember, phrenic is the term for diaphragm. So it is occurring very near to the diaphragm or lower part of the esophagus. Epiphrenic diverticulum. Now, regarding the treatment of achalasia, we need to go for surgery. Now, before I move further, please have a look at this slide. All of you, please pay attention here. These are the major conditions which are associated with esophageal motor dysfunction. So let me use the pointer and explain to you. Now look carefully here. This is esophagus. Here is the stomach. Okay. This is diaphragm. Now see here, the lower end. Okay, the lower end of the esophagus, or we can say lower esophageal sphincter. Okay, is contracted here. It is not opening. That's why this area is acutely narrow. Acutely narrow. And to diagnose this achalasia, we can do certain tests. Okay, one is called barium swallow. We give barium to swallow and take the X-ray. During this time, because of this very narrow segment of the esophagus, a slight amount of barium will only pass through it and go to the stomach. This is called bird beaking appearance. Okay, bird beaking appearance. We'll talk this again when you go to the clinical side. This is more important there actually. In pathology, we don't talk about investigation usually. Okay. Now, another is called hiatal hernia. See this. Now, this is esophagus again. Here is the stomach, and this is the lower esophageal sphincter. Now, see here, the lower esophageal sphincter itself is herniated above the diaphragm and present in the thoracic cavity now. So, this is sliding type of hiatal hernia. The LES, lower esophageal sphincter, is present in the thoracic cavity. It is herniated upward, sliding hernia. Another type of hiatal hernia is also there, which is called paraesophageal hernia. Okay. Now see here, the lower esophageal sphincter is still present in the abdominal cavity or below the diaphragm, but one small part of the fundus of the stomach is herniated upward. This is paraesophageal hernia. Now, these two have a different presentation because of the laxity of lower esophageal sphincter. Now, it doesn't function properly. There is regurgitation very easily happening here. So, the patient will have GERD sign and symptom. That means gastroesophageal reflux disease will occur in this situation. So, we have chest pain, which is called heartburn, okay, burning type of pain, all those things happen. And Barrett esophagus is one of the chronic complication of sliding type of hiatal hernia because of GERD. Whereas paraesophageal hernia doesn't have those features because the LES is still present in the abdominal cavity. But there is a high chance of ischemia now. This part can develop ischemia and can undergo into necrosis. That is another big type of complication. Now, just compare these two things, Juncker diverticulum and epiphrenic diverticulum. Now, both are diverticulum, means there is outpouching from the mucosa. Okay, one is occurring above, means upper part of the esophagus, and another is occurring lower part of the esophagus. That is the difference. This epiphrenic diverticulum can be a complication of Achalasia cardia, which we have just listed. And Juncker diverticulum may be congenital or may be acquired. We'll talk a little bit about Juncker diverticulum after this slide. Now, the last one in this picture is Mallory-Weiss tear. This is a rupture of gastroesophageal junction mucosa, and this usually happens because of severe retching or vomiting. Okay, retching or vomiting, and in alcoholic, usually this type of tear happens. Now, what happens after this tear occurs? There is severe bleeding, and that blood may be vomited out. Okay, may be vomited out as a bright red blood, or it may go distally and come out as a melena. So, hematomesis and melena are an important feature of Mallory-Weiss tear. So, nobody is going to ask you these things in detail. Just they will want to know what is the meaning of these terms. Now, see here, there is one condition known as Junker's diverticulum, which is slightly more importantly asked than other. So, let me highlight this. This is pharyngoesophageal diverticulum. Pharyngoesophageal diverticulum. See here. It is present at the upper part of the esophagus. Sometimes it involves the part of pharynx as well. That is the meaning. Also known as pharyngeal pouch. Pharyngeal pouch. It is a diverticulum of the mucosa of the pharynx, just above the cricopharyngeus muscle. Okay. One S is left here. Okay, cricopharyngeus muscle, that is above the upper sphincter of the esophagus. Though it is written as dysfunction or disease of esophagus, frankly speaking, according to the anatomy, it is a problem of pharynx. because it is occurring above the upper sphincter of esophagus. Now, what will happen in this condition? Listen carefully. This is a diverticulum, means this is a pouch, and when we swallow our food, some of the food may go there, okay, and accumulated. Not only food, even drinks will be accumulated there. Now, after that pouch is filled with fluid or food, it may act as a mass, and that mass can give pressure to the esophagus or that part of the pharynx. Now, this is called dysphagia. Okay, dysphagia, difficulty to swallow. After this pouch is filled, it can have regurgitation, and regurgitation can easily result in aspiration. Now, halitosis means bad, foul-smelling breath. Now, this person will have bad and foul-smelling breath because the food which he or she has eaten even 2 to 3 days ago is still accumulated there, and those food will be degraded by microorganisms, of course. So there will be foul smelling gas release. So if a person comes with halitosis, one of the differential diagnosis is pharyngeal pouch. Only one. There are so many other causes. Now, another important point here is, cough. This cough is because of regurgitation or aspiration. Now, one very important point, that may be a diagnostic point here. This person will vomit because of regurgitation, and that vomitus or vomiting contains the food which that person has eaten, yesterday or day before yesterday, or 1 or 2 days before, and the person will be quite surprised to see this food I have not eaten today. From where this food is coming? Okay, because the food is collecting there inside the juncus diverticulum or pharyngeal pouch. After you diagnose it, the treatment is surgery. Now, another condition which I like to highlight is Mallory-Weiss syndrome or Mallory-Weiss tear. What do you mean by this? See here. Now, a little bit description I already gave to you. This is a longitudinal laceration or tear at the gastroesophageal junction produced by severe prolonged vomiting. So this is laceration, okay, laceration at gastroesophageal junction. And it is produced by severe prolonged vomiting. This is important point. It is also known as retching, because before vomiting, the alcoholic will retch, okay, and during that time, a lot of pressure is generated inside the stomach, and that part of the mucosa may just rupture or lacerate. So alcohol intake is the most common cause. So we need to take a good history. Okay, do you drink alcohol or not? We need to ask that question. Regarding the presentation, the most common one is hematemesis. This is vomiting of blood. Another one is melena. Melena occur if there is massive type of bleeding. Now remember, from where the bleeding occurring here? From the upper part of the stomach, very near to the esophagus. That's why most of the blood will be vomited out. If something is left behind, then that blood will change into acid hematine by hydrochloric acid, and now it will go distally and come out in the stool as melena. But melena is not the major problem in this case. Now, when we examine it grossly, we can see that laceration here. It is a linear type of laceration at gastroesophageal junction. It is millimeter to centimeter in length, sometimes very small, sometimes a bit bigger, and it typically involves only the mucosa. Okay, this is far more common, but sometimes maybe full thickness tear can be there. All 4 layers may be torn. but that is very rare. Mucosal ton is more common. What are the complications of Mallory-Weiss syndrome or tear? Sometimes massive hematomesis can occur, and this hematomesis can result in hemorrhagic or hypovolemic shock. If bleeding is excessive, then the person can have hypovolemic shock. It can result in inflammation. It can result in residual ulceration if it doesn't heal properly, and if it is very severe, then the infection may spread out, resulting in mediastinitis. Now mediastinitis is the infection of mediastinum, so that is one of the very severe type of complication. And another one, esophageal rupture, that is rare. If full thickness tear occurs, we call that esophageal rupture if it occurs in the lower part of the esophagus. But already told, it is a bit rare condition. So this is Mallory-Weiss syndrome. Just know the meaning here, okay? And what is the most common cause. Now, after Mallory-Weiss syndrome, let's talk about esophageal varices, another important condition. What do you mean by that? Let's start with the meaning. They are dilated submucosal vein in the lower third of the esophagus. Now see here, this is the pathological specimen of esophagus. It is cut open anteriorly, and see here, I can see this dilated area. These are the varices. Here also, okay, these are very typical. These are the varices. So they are dilated submucosal vein in the lower third of the esophagus, and it usually develops there secondary to portal hypertension. Now let me talk a little bit about portal hypertension here. There are different causes of portal hypertension. Okay, one is portal vein thrombosis, another one cirrhosis of liver, and third one may be post-hepatic causes. That is a special topic for us, so we'll discuss in detail during that time. For the time being, just know few of the points. Now, portal hypertension means there is excessive pressure in the portal vein, or the portal vein is blocked or obstructed. Means forward flow from the portal vein into the liver is a difficult thing there. Now what will happen? The venous drainage will try to reach towards the right side of the heart by some alternative pathway, and that one of the alternative pathway is lower end of the esophagus, and at that place, okay, there is a anastomosis between portal vein and systemic vein. Portal vein and systemic vein. And when these anastomotic veins are dilated because of portal hypertension, we call that esophageal varices. Now, this is not the only area where portosystemic anastomosis occur. Another area is around the umbilicus, and if that veins are dilated, we call it caput medusa. Okay. Third one, okay, in the rectal area, the rectal area. So these three are the most important one. The fourth one is also there in the bare area of the liver, and fifth occurs in the retroperitoneal area. So let me repeat again those portosystemic anastomotic area. One, lower end of the esophagus, which results in esophageal varices. Second, around the umbilicus or periumbilical area, which results in caput medusa. Third, in the rectum, and there are hemorrhoids, we call it hemorrhoids, okay, a similar type of condition like varices in that area. Fourth, in the bare area of the liver, and fifth, in the retroperitoneal area. Now let's focus ourselves on these esophageal varices now. So the most common cause is portal hypertension because of cirrhosis of the liver. because cirrhosis of the liver is the most common cause of portal hypertension. That's why it is written like that. Now, how these patients present? See here, they present in the beginning, probably they are asymptomatic. That means if they are not ruptured, okay, they are asymptomatic. But anytime this dilated vein can be ruptured and they lead to massive hematomesis. Okay, that blood is coming from the vein, the ruptured vein, and it is very difficult to stop them. Stop the bleeding, I should say. Okay, and sometimes the patient may die because of fatal hemorrhage and hypovolemic shock. So this is a special topic which we will deal with in medicine and pediatric. But a little bit knowledge I want to provide you right now. We have to stop this bleeding anyhow if we want this patient to survive, and that can be done by endoscopy. Okay, this can be done by enough pressure which is applied here through balloon tamponade and endoscopy. So these are two main ways. Some other ways are also there, like ligation of these varices, and even sclerose them by injecting some sclerosing substance. Okay, so let's start again. We're talking about different pathology of esophagus. Now, another important condition which occur in esophagus is reflux esophagitis after gastroesophageal reflux disease. So let's talk a little bit about it. Now, this is a condition where there is inflammation and irritation of esophagus occur as a result of reflux of gastric secretion into the esophagus. Now, let me talk about a little bit of physiology here. The lower esophageal sphincter is preventing the reflux of gastric secretion upwards towards the esophagus. If something wrong occurs in that lower esophageal sphincter, if it is lax, okay, if it's not working properly, or if there is too much pressure developed inside the stomach, then those gastric secretions can still go up. And this is called GERD, or gastroesophageal reflux disease. Now see here, what can happen to the patient? Patient will have heartburn. Heartburn means the esophageal mucosa is inflamed as a result of acid contact and regurgitation. This regurgitation can easily lead to vomiting as well. Okay, not only vomiting, sometimes this regurgitation can also lead to aspiration. Vomiting and aspiration can happen. Rather than complete type of vomiting, this regurgitation means a bit of secretion from the stomach is reaching up, maybe into the pharynx or even in the oral cavity, and that patient has a sensation of shower type of fluid in the oral cavity. That's the sensation of hyperacidity and regurgitation. The contributing factors for GERD are decreased efficacy of esophagus anti-reflux mechanism. That means the lower esophageal sphincter is not functioning properly, and there is delayed gastric emptying and increased gastric volume. I already told you, because of these two factors, there is increased pressure inside the stomach. So it will push the things further upward, and especially if the lower esophageal sphincter is not tight or lax, then easily the things can be refluxed upward. One of the commonest predisposing factor for GERD is obesity, even overweight and obese people. Overweight may be question marks, but obesity definitely. And let me give you a little bit clinical scenario here. An obese person, okay, after taking a big meal, he has gone directly on the bed, okay, and he lie down there, and he even did not put enough pillows, just one pillow was there. This is the perfect situation for reflux esophagitis or gastroesophageal reflux disease. So what are the things to do there? First of all, he should eat a little bit less. Second, he should not lie immediately after taking food. And third, he should put more pillows there so that the upper part of the body should be elevated. All of these are important points to prevent from reflux esophagitis in case of obesity. Now, what is the morphology of GERD? If we look at that area is red, okay, hyperemia and edema. There is infiltration by neutrophils and eosinophil. The eosinophils are important cells here, okay, eosinophils, and there is superficial necrosis as well as ulceration. Superficial necrosis as well as ulceration. Some complication can occur as a result of GERD, reflux esophagitis, and they are bleeding. Now, this bleeding usually presents as hematemesis or vomiting of blood. That blood is usually bright red blood. Stricture. Stricture means narrowing of the lumen of esophagus, and that occurs because of chronic inflammation and fibrosis. Bronchospasm and asthma occur because of aspiration, which is associated with reflux esophagitis. This aspiration is not, simple type of aspiration. It has got hydrochloric acid there, okay. If that hydrochloric acid enters into the airway, it can cause bronchospasm, and if this patient is already having bronchial asthma, then the attack of bronchial asthma may occur, and it is very difficult to treat also. We have to give this antipeptic drug for the control. And the last one, if this condition is not treated in time, if this condition becomes chronic, then what will happen now? There will be metaplasia. Okay, there will be metaplasia. The normal epithelium of esophagus is stratified squamous epithelium, and that stratified squamous epithelium will change into columnar epithelium, and that is called Barrett esophagus. Okay, this is not a good condition to have, because after some time it may complicate into dysplasia, and dysplasia may complicate into malignancy. Now, the type of malignancy which develops from Barrett esophagus is adenocarcinoma. Adenocarcinoma. Now, look at this picture here. Okay, this is quite an important one. Let me show you with the pointer. Now, A is the normal gastroesophageal junction, which is shown by this arrow. You see this? This is the stomach mucosa. Okay. You can see the rugosities or rugae here. These are the mucosal folds of the stomach. And look at this epithelium, which is very pale. The pale looking epithelium is called squamous epithelium, and this is a junction between them. So this is the normal thing. Now, because of chronic reflux of the acid from the stomach upwards, look at this here. This arrowed area is the normal gastroesophageal junction, but in this case the gastroesophageal junction has moved way up. You see this, okay, this area. Now this whole area is called metaplasia, because earlier this type of epithelium was present here. Now it is converted into red looking epithelium. Now, pale epithelium was stratified squamous. The red looking epithelium is columnar one. So columnar is replacing the squamous. So this is called metaplasia in this site. This is the endoscopic view of Barrett esophagus. Okay, look at this. This red epithelium is extending upward. These are the wonderful pictures of Barrett esophagus. With this, the last part of the topic is left behind. in this esophagus pathology, those are the malignancy. So the first one is squamous cell carcinoma. Let's talk about it. This squamous cell carcinoma is the more common type of esophageal cancer than adenocarcinoma in the whole world. Male are more commonly affected than female, and the common age is usually more than 50 years. So it is seen in older people. And squamous carcinoma is more common than adenocarcinoma. Now, it depends according to the country also. In some of the country where obesity is maximum, okay, a lot of population is obese, adenocarcinoma may be more common than squamous cell carcinoma as well. So it always depends on many different factors. Now, what are the presentation of squamous cell carcinoma? See here, this is a very important slide. It is often asymptomatic in the beginning until late in the course. Now, many people, they develop difficulty in swallowing in case of carcinoma of the esophagus, but some people ignore it, they take it very lightly. They think, oh, this is just, once or twice I am having this, so why to go to the doctor? So they don't go. And by the time they develop this consistently, it is already very late. Most important symptom is progressive dysphagia. This has to be the most important symptom in this case. So let me underline it. Progressive dysphagia. Now, progressive means it is increasing day by day and week by week. Okay. In the beginning, there is difficulty to swallow the solid food, but later on, when complete lumen of the esophagus is blocked, even the liquid cannot be swallowed. Udinophagia is painful swallowing. So dysphagia is difficulty to swallow. Udinophagia is painful swallowing. That is the difference. Weight loss and anorexia. This is malignancy. Any malignancy in our body will be having this symptom. Okay, any malignancy. You can take any malignancy here. Bleeding. Now, one more reason I can give for weight loss here, because the person is unable to swallow. Okay, the person is unable to swallow. When the person is not, swallowing the food, okay, definitely weight loss will be there. Now, bleeding. Now, this mass, okay, which is present at the lumen of the esophagus may ulcerate. It may bleed from there. Okay, so bleeding is also quite common. Now, this bleeding can come out as hematemesis. Hoarseness of the voice or cough occur in advanced cancer. Now, you have already dealt with malignancy in detail in third trimester. Okay, so let me, remind you some important points from there. Benign tumor and malignant tumor has few important differences. The most important two differences of benign tumor and malignant tumor are local invasion and metastasis. Now, as a result of local invasion property, the nearby area are infiltrated or destroyed or damaged by the malignancy. Now, we are talking about esophagus here. Okay, so the nearby structures are larynx, okay, trachea, isn't it? We have a vagus nerve, we have phrenic nerve, we have sympathetic chain, okay, we have thoracic duct. So many important structures are there. So all of them can be affected. So if larynx is involved, then we have hoarseness of the voice. So this is the feature of involvement of the larynx, or you can say involvement of the recurrent laryngeal nerve. So hoarseness of the voice. And cough, because cough receptors are present everywhere in our airway. So cough is an important feature in advanced cancer. Advanced means when it is infiltrating the nearby area. Aspiration pneumonia, because of complete obstruction, okay, the person is unable to swallow, so there is accumulation of fluid which may trickle forward into the airway, resulting in aspiration pneumonia. Superior vena cava syndrome is because of obstruction of superior vena cava or blockage of superior vena cava by the tumor, or it can also occur by the affected lymph node sometimes. Now, superior vena cava has some important function. It is collecting all the venous blood from the head and neck area as well as upper limb area and draining that blood into the right atrium. When this big blood vessel is blocked, okay, venous drainage cannot happen. So there is congestion. Congestion occurs in the upper part of the body. Now remember, if congestion occurs in our brain, it will lead to cerebral edema. It will lead to raised intracranial pressure. If congestion occurs in the face, the person looks very red in color and the person's face is swollen as well. And the upper limbs are also edematous. Now, due to distant metastasis, a lot of other clinical feature will be there. Okay, wherever it goes, it can damage that tissue, like liver, bone, brain. All these things can be explained. Now, what are the risk factor of squamous cell carcinoma of esophagus? Now see there, the risk factors are dietary risk factors like deficiency of vitamin A and C. Okay, vitamin A and C are antioxidant. So if we do not take them in enough amount, okay, then the cancer can happen. So we always say we have to include fruits and vegetables in our diet because they have a more source of antioxidant like vitamin A and C. If there is a deficiency of zinc, it can also lead to development of cancer. Processed meat increases the chance. Okay. Processed meat means those meat which are easily available to buy in the market, okay, like all those sausage, salamis, and the processed meat. The other type are also there. Drinking hot liquids for a long time. Now, drinking hot liquid for a long time. So this is a bit of controversial actually. These are all hypotheses. We have not actually proven them. Most of the malignancy, it is the fact. So drinking hot liquids for a long time can erode the mucosa, or it can damage or harm the mucosa of the esophagus, and over a period of time it may turn into malignancy. That is one of the hypotheses. But some of the people, they drink this hot liquid all the time, isn't it? Like Chinese people they drink hot water. They don't like to drink cold water like us. Betel chewing, okay, one of the important risk factors, which is very common in South Asia. We love to chew betel, especially after we eat food. That is not a good practice, both for oral cavity, pharynx, as well as esophagus. Regarding the lifestyle risk factors, alcohol, okay, and smoking or tobacco, both are quite damaging for the esophagus and they can cause esophageal cancer. The more important one is alcohol here. Regarding the esophageal disorders, long-standing esophagitis, Achalasia cardia, and Plummer-Vinson syndrome, all of these are risk factors for the development of malignancy in esophagus. Achalasia and Plummer-Vinson's are more important one. Now see here some of the important points. Age, it is more common in older age. So older age is a risk factor and more common in male than the female. Now regarding the hereditary factor, it is more likely in those people who have close relatives with cancer. So it may run in the family. So we need to take good family history. And inside the family, if a person is already having esophageal cancer, the other can also have it. Obesity, one of the important factor, though not directly but indirectly. Obese people, they do not have a good dietary habit. They just like fatty food. They probably are not taking enough fruits and vegetables in their diet. They take a lot of meat, remember that. And that meat, even the processed and unprocessed both, can lead to a chance of esophageal cancer. One of the important condition is called tylosis. Okay, now see here, what is this tylosis all about? Tylosis is a rare inherited disease which causes excess growth of the top layer of the skin on the palms of the hand and soles of the foot. So in this condition, the palm and sole are having excessively thick skin. This is tylosis, and this is inherited condition. Now same tylosis can also have a small growth in the esophagus, which are called papilloma, and these papilloma have high chance of progressing into squamous cell cancer. So in the MCQ exam, we may ask this type of options to you. All of the following are risk factor of carcinoma of esophagus, except like that, three options are the risk factor, one is not there, and you need to choose that fourth option if this type of question is asked. So tylosis is one of them. Stricture of esophagus is another risk factor. This is a narrowing of esophagus which is leading to obstruction. And last but not the least, human papilloma virus. This is a DNA virus which can lead to cancer of head and neck area. It is also causing cancer in female. Remember the cancer of the cervix in female, human papilloma virus, we all know that. But these days, the researchers have confirmed that even the head and neck malignancy or cancer are caused by human papilloma virus. Now see here, what is the prognosis of squamous cell carcinoma of esophagus? This is one of the cancer which has got poorest prognosis, poor, extremely poor. And there are multiple reasons for this, because most of the patients, they don't present earlier when they are having symptom. When the symptom or the disease is very late or advanced, then they come to the hospital with dysphagia, and by that time we cannot do anything. So the overall 5-year survival rate is about 15%. So 10 to 15% is the 5-year survival rate. 10 to 15%. So it is one of the cancer which has got poorest prognosis. Now see here, okay. Now this is a real pathological specimen, which is showing us a big mass here. Look at this mass. Okay, you follow this pointer. See this whole thing is a mass. At the center of the mass there is ulceration. This is ulcerated area right here. So this mass will definitely leads to obstruction, which is causing dysphagia. Another thing, it is causing bleeding because of ulceration. And so many other features can happen now. If it has gone out of the esophagus, okay, in this area it is already a little bit trying to going outside. All those pressure symptoms and local eroding property and all those things will appear here. Now another type is the adenocarcinoma of esophagus. Now, adenocarcinoma of esophagus arises more commonly in the distal third of the esophagus. And the most important cause for this is Barrett esophagus, which develops into dysplasia, and after this dysplasia, cancer will develop. So Barrett esophagus is the most important cause, and you can explain the whole pathogenesis here. Okay, so let me show you that pathogenetic slide now. See here. This is the transition from Barrett esophagus to adenocarcinoma esophagus. So it can be included as a pathogenesis here. Okay, see this. So this is the normal squamous epithelium of esophagus. Normal squamous epithelium of the esophagus. This is the basement membrane. Okay, This is the basement membrane. Now, because of the reflux of the acid, it has developed esophagitis or inflammation. If this process continues, then metaplasia develops. Now, this squamous epithelium is changed into columnar epithelium. You see this? This tall-looking, epithelium is a columnar epithelium. This columnar epithelium belongs to stomach. That means the esophageal mucosa is changed into stomach mucosa. You can also remember like that. After that, dysplasia will occur. Dysplasia means disorganized cells. Disorganized cell. And finally, carcinoma occur. This is called invasive carcinoma. Now, where is the basement membrane? Here, it is already broken. It is already damaged, and the cancer cells are present, below the mucosa or in the submucosal area. And one important point is, these are gland forming cell. That's why we call them adenocarcinoma. Adenocarcinoma means they form the gland. Now, genetic alterations are well documented in adenocarcinoma. Means the people are already genetically predisposed, though we don't know which genes are those, but they are speculated. Regarding the gross and microscopic morphology, grossly it looks like there are exophytic nodules. There are exophytic nodules which will form cavity later on, and they can also deeply infiltrate the surrounding area. Excavation means cavity formation. Exophytic means they are growing into the lumen, from the mucosa. And infiltration means they are infiltrating the wall of the esophagus. So all of these things may be there. Microscopically, they are mucin producing glandular tumor. Mucin producing glandular tumor. So see there, that's why they are called adenocarcinoma. They are glandular tumor and they produce mucus or mucin with intestinal feature. Or intestine means they have got tall columnar cell. That's why this point is written. You can also write they look like stomach looking cells. Now prognosis is really poor here. And the prognosis is just like the squamous cell carcinoma of esophagus. And regarding the treatment of both of these conditions, surgery should be done. Surgery is the mainstay actually, and that affected part is removed, and it is changed by a prosthesis, because you cannot do end-to-end anastomosis if a part of the esophagus is cut and removed, because esophagus is a tube, isn't it? I cannot pull it through. It is not like a intestine which is very long, which is a coiled structure. It is a straight tube, so I cannot pull it. So if I cut one part of the esophagus, I need to replace with a prosthesis. Now look at this picture here. This gives you a very important idea. This is the gross morphology of adenocarcinoma of esophagus. Adenocarcinoma of esophagus. See here. It is going up and up towards the lower end of the esophagus. Look at this area now. There is a big cancer development here. This area. There is a big mass and there is excavation there. Now this is the histopathology of adenocarcinoma of esophagus, and they are gland forming cells. The glands are formed here and there. So at the end of this topic, I prepared some questions for you. So you can go through these questions and then you feel confident about this topic. Now